Afternoon, everybody. Hope you had a nice lunch. On my phone, it's 2 o'clock, so I'd suggest we start this session. My name is Pim van Ooy. I am at Amsterdam UMC, and I'm moderating this session together with.
And I'm Patrick Winter from the University of Greifswald.
And our session is called Flow Modeling and Processing. And our first speaker is Sebastian Kutzerke from ETH Zurich, who will enlighten us on MRI encoding and decoding of flow across scales.
Well, thanks, Pim and Patrick. So pleasure being here. So I wanted to say a few things about flow at various scales and how we do encode and decode those various scales. So let me start with something that's pretty old by now. 20 years ago, we acquired that type of data and looked at the vortices in the just downstream of the aortic valve with some reference to Da Vinci's codices long time ago. These kind of vortices are sometimes referred to as turbulent flow. They are not, right? So these are secondary flow patterns, well-behaved, no statistical feature in that flow. And just to be kept in mind, right? So not every vortex is turbulent or stochastic flow. All right, so when we start seeing turbulent flow is when the aortic valve orifice is being reduced, and that's aortic valve stenosis. So I just quickly go through that so you all know that. So progressively and increasingly the orifice area reduces. There's something interesting happening here. There's a phenomenon called pressure recovery and pressure loss. So if we sort of look, and perhaps I can use the mouse here, let's see. Yeah, if we look at pressure, so pressure drives flow, as we all know, right? So against an impedance along the axial direction. So we have effectively the pressure that goes down and then sort of recovers a bit, right? And that's something that people have looked at very carefully. And that now relates to some conversion of kinetic energy of mean flow into turbulent flow kinetic energy and then reconversion back. And clinically, what people would do is to look at the max velocity downstream of the valve, right here, you max, and then sort of use the simplified Bernoulli equation or modified Bernoulli equation to compute the pressure gradient. And we argue it's not the right way of doing it. Let's have a look at that. So if we just go a bit further, so we have the mean pressure gradient, so with reference to echo, and then we have the net pressure gradient. That's what we think everyone should be interested in. So we can also state that very often we see that the max gradient is way bigger than the net gradient, and the net gradient is actually what causes the additional burden to the left chamber. All right, so the healthy valve on the left, the stenotic valve on the right, and we can see that the net energy loss is very different and should be characteristic for the valve severity, stenosis severity. All right, so we want that. So how can we get there? Well, classically, we look at single sources moving in a deterministic fashion, so at a constant speed or varying speed with some acceleration. And we all know the concept, right? So the concept of phase contrast using bipolar gradients. Bipolar gradients in the presence of moving magnetization will cause a quadratic phase evolution as opposed to static spins in gray here. Now the moving spins would gain phase as in this example. Of course, we all use that to get the mean velocity per voxel. Okay, and that of course works well. So we, and this is again pretty old data, I should say, 20 years old. A comparison of healthy volunteer pass line tracking and a patient with dilated aorta. And yeah, our recommendation in the field is to acquire that type of data with 2.5 millimeter resolution, roughly isotropic, and a temporal resolution of 40 milliseconds. Let's keep these numbers in the back of our head, because that also, in the end, tells us that we have to take another mechanism, another path to look at turbulent stochastic flow. Well, once we have these velocity vector fields, we can look at derivatives in space, wall shear stress. Well, we have to be careful here because the boundary layer in the aorta is only 0.9 millimeters roughly, so the viscous boundary layer, so meaning that wall shear stress estimates become dependent on resolution. But that has been done very carefully, and so people have looked at various mechanisms, various correlations between wall shear stress estimates and disease severity. All right, so but that's to be kept in mind here, so that yeah, increased wall shear stress estimates are associated with decreased elastic fibers and matrix degradation. All right, so the other things that can happen, so that's an example that we acquired probably 10 years ago, kinking in the aorta. Some anatomical malformation where the flow has to go by. And that also causes some interesting flow features, whether they are turbulent, we don't know. At that time, we didn't really look at that carefully, but certainly secondary flow patterns develop here and could be of interest. All right, turbulent flow, what is it? So just a quick primer. Turbulent flow is flow that's stochastic at any point in space, or it is stochastic in both space and time. So if I would take just a probe point in blue here, so that's this little dot that we see right here, and just record velocity over time, I see that kind of noisiness. And what people would do is would say, okay, I measure that, look at the distribution, so I get now a mean velocity and a turbulent fluctuation on top. And once I know the fluctuating velocity, I can look at the root mean square, energy content of that turbulent flow and make an estimate. Unfortunately, our resolution isn't good enough to look at that single point. What is important in terms of turbulence also to know is that, well, turbulence becomes dissipative only at a very fine scale. So we started off with kind of vortices downstream of the aortic valve. So that will be what we call the integral scale L. So that's where energy is sort of injected. And then we trickle down. So by viscous friction, we only arrive at the finest scale. So that's the scale we call Kolmogorov scale. That's down here. And that's where energy dissipation happens due to molecular friction, right? At any other scale, so we can always convert back, meaning there's no energy lost, right? So if I have intermediate vortices, so that energy gets converted back into mean flow again. So no energy lost, so nothing that we need to care about too much in that context. All right, so let's have a look at a few numbers just to have an idea. So mild aortic stenosis in one column, severe aortic stenosis to the right. Please forgive the formatting issue, so probably an issue with PowerPoint here. So the Kolmogorov scale is 0.1 millimeter, way beyond of what we can resolve. The temporal time scale of these scales, these fluctuating velocities, 3.6 milliseconds, roughly, beyond what we can achieve, right? So that's 1 TR, so we can't resolve that. So unfortunately, with current protocols, with MR technology per se, we are not able to resolve it directly. Now, what can we use here? Essentially, we just take now well, all the learnings from diffusion imaging. So we just look at intravoxel dispersion of phases, and that's basically this kind of thing, right? We have a mean flow, and on top we have some fluctuation, and that fluctuation is meant to happen within a voxel of 2.5 millimeter cube. And if we do that, so essentially the assumption is that our little dot, our probe point, has become a big box, right? And the hope is that we see the same characteristics of velocity fluctuations in that box, and on a certain assumption, so that indeed can be observed. So taking a big voxel and looking at the phase dispersion in that voxel, and in the end, a magnitude reduction allows us to sort of tap into that fluctuating field. But yeah, so we don't really get the information at a single point, of course not. And then we can define the Reynolds stress tensor. So these are essentially the variance and covariances of fluctuating velocities along all dimensions. We just multiply that with the density of the fluid. And then we can, for example, compute turbulent kinetic energy, which is this trace, so the diagonal of the Reynolds stress tensor. If we do that, so we can extend our signal model, our phase contrast signal model, by a magnitude term that is seen here. So we have now the variance of the velocity fluctuation of kV. So that's our first moment, gradient first moment, that goes into a magnitude term. And then we have the phase of phase contrast measurements as usual. So you can plug that together. So you have now magnitude contrast with phase contrast, and that magnitude contrast allows you to get an idea about the Reynolds stress tensor. We write the tensor down here, so then effectively you have a vector of encodings you have to do along various directions at various strengths, and then you have the Reynolds stress tensor right there, and then you just have to multiply again with the vector of encoding. And it has been developed over many years, so initially introduced by Penta Dieverfeld, then taken on by various groups, including ours. And now that brings us into something that looks like diffusion imaging, in fact, because we now consider not the Q space for encoding, but we consider the KV space of encoding, and we can choose various points to encode. For example, the classical 4-point scheme could be used. It has turned out not to be optimal for turbulent mapping, so rather you just go to a 7-point scheme or any other higher order scheme to derive the tensor. And that works well. Again, a bit older work that was done in Zurich, so to look at the energy loss or the turbulent kinetic energy integrated. So the unit would be joules per cubic meter. It tells you that, well, indeed, downstream of aortic valve, stenosed aortic valve, so there's a huge amount of turbulent kinetic energy. It's dynamic, of course, time resolved, and you look at the meaning of it. And it turns out now it sheds light on the problem that I mentioned in the beginning. So classically, in ultrasound, you would look at the mean pressure gradient, so based on the max velocity downstream of the valve. And now let's compare the numbers. So let's take the left example, 35 millimeters mercury, mean pressure gradient, and the peak TKE was 53 millijoules, integrated now over space. And we take that example that appeared to be more severe in clinics, so a much higher mean pressure gradient, yet much lower TKE, right? So in principle, you would say now the problem in that left column is much less because there's less turbulent kinetic energy that is present. And that indeed helps to stratify patients a bit better. So left-hand side, echocardiography based, mean pressure gradient, energy loss index, ELI. And then looking at the discrimination with TKE, so you can see you get more information out. In order to now get this kind of 7-point or even higher point encoding, you have to accelerate. We now use essentially what many people are using, more advanced steady state type self-gated acquisitions. It looked like this, so 5D flow MRI as described back in 2019. So acquiring the data, then binning the data along respiratory and cardiac phase dimensions, trying to solve that. So acquisitions can be rather fast. Usually in practice, we just acquire over 10 minutes to have enough information encoded, enough SNR and VNR, velocity to noise ratio. Then you start reconstructing different respiratory bins perhaps, but also the information that we're after. Now, given that the recon problem is now quite challenging, it takes a lot of time, so people have invested into speeding it up. So now we have various types of recons using more like variational networks or deep networks or other forms of self-consistent learning. And for example, we had Flow VN, that was the first one that was introduced, so that did the job in under a minute. Now we have Flow MRINet, a bit more advanced, self-consistent learning, QR code for those interested in deploying it. That is actually working with the very same data, no longer needing training data, separate training data. So that works quite well. And with that, given time is over, so a quick summary. 4D flow MRI allows for comprehensive assessment of aortic flow and other flows, of course. I wanted to show you and to convey here the theory behind extended encoding to enable both mean and turbulent flow quantification. Thereby, we get and can tap into energy loss mechanisms that are relevant because they will put the burden or increase the burden to the heart. And and then of course the more advanced acquisition schemes allow us to embed these additional encoding points. With that, and with all the high-speed recons, I can finish up here. Thank the team back in Zurich, some individuals as well, and thank you for your attention.
Thank you, Dr. Kotserke. I think we have time for one quick pressing question from the audience, if there is one. Otherwise, I have one. Because you commented mostly on the spatial resolution for turbulent kinetic energy for fluctuation quantification. But isn't it really important to have a high temporal resolution as well for fluctuation quantification?
The encoding happens within the TR, right? So essentially the phenomenon we are looking at is intra-TR. So hence the temporal resolution usually we define as a multiple of the TR, right? So that's what we said. But the temporal resolution in that sense doesn't play a big role. So you can even do like a long hard phase interval, you still see the effect. But of course, if you start studying deceleration effects, for example, you want to resolve the deceleration of flow, because that's where flow becomes unstable, and hence you should look at it. But going towards below TR encoding, of course, isn't possible, right?
Thanks very much. Then if there are no further questions, I'd like to invite Dr. Suzanne Schnell, Professor Suzanne Schnell, to the stage to talk about 4D flow MRI post-processing and automation.
Hello, everybody. Yes, thank you for this invitation to speak today and give this educational talk about 4D flow MRI processing of the data. For how to, yes. So I thought, Sebastian was the one explaining all the sequence stuff, and I probably don't have to explain much anymore about 4D flow MRI and how it is acquired, but I still also would like to touch a little bit on the motivation of why we acquired. So one of the first things, I think, how it started was that people actually appreciated the visualization of blood flow in a human body. Here you see an example of a vein of Galen malformation. So this was a small baby born with a malformation in the cerebral arteries. And as you can see, there's actually, I don't know how to go back and forward. No, yeah. As you can see, there's a giant formation of an aneurysm in this newborn. And this is actually what we would like to study and to investigate using quantitative numbers. And this is where I want to bring you today, how to do the post-processing. So what do we want to do? We want to understand the influence of the hemodynamics on pathologies. For example, why do we have maybe aneurysm formation? Why do we have formation of plaques? Is there actually is the blood flow potentially also responsible for the rupture of aneurysm or plaques? So these are the questions that we want to answer, but also for complicated intracranial or cardiac anatomies, congenital anatomies, we might actually monitor the disease progression or even the treatment success using 4D flow MRI. And there are many more motivations of why we would want to look at data like that. So Sebastian already said, so we typically acquire 4D flow in the chest with about 1.5 and 2.5 millimeter isotropic. This takes, depending on the sequence, how modern your institution is, can take anything between nowadays 4 and 15 minutes. And we call this then 4D flow MRI because we have a 3D volume and the temporal, the time domain as well. And we call it flow because we typically, in 4D flow, we do acquire 3-directional velocity encoding. In the brain, it looks slightly different. Here we would usually go or like to go to higher field strength. So we usually like to go to 3 Tesla. We measure with in the chest, we would measure with a Wenck of 150 or 200, depending on if we want to look at stenosis or not. In the head, we are a little bit lower. We also go to lower spatial resolutions. So what people typically do is between 1 and 1.5 millimeter. I actually like to be a little around 1 millimeter and below in the head. And of course, because of the high spatial resolution, we usually need longer to acquire the data. So it's typically, depending on your acceleration, between 10 and 15 minutes in the head. But it doesn't matter where you acquire your 4D flow data, you actually always have to go through a certain processing pipeline. So you start with your magnitude image and your your 3 phase encoding directions, and then you have to do a long list of pre-processing steps. To start with the corrections, the phase offset corrections, anti-aliasing. Then you have to do noise corrections, calculate a phase contrast angiogram, do a segmentation. Sometimes, depending on what you want to analyze, you take then the segmentation to do a volumetric approach to find a peak velocity, or you then use a center line approach to then position analysis planes along your center line to get all the quantitative numbers that you want to get out. Of course, once you have your angiogram, you can then go and visualize your data, which already is a big step for the treating physician to look at. And then once, then you finally can get your quantitative numbers. So let's look at that. So the corrections, the most important correction, in my opinion, because you want to avoid phase errors. If you have a phase error, you have an error in your velocity quantification, and phase errors occur because of phase offsets. So you make an error in the acquisition of your phase. That means that can come, for example, from eddy currents, that can come from Maxwell terms, and you actually want to achieve that the velocity where it should be 0 is actually 0. So that means here you see a static. Is this? I don't know how you did this. Yeah, anyways, you can see there that this is a static phantom. And the phase should actually be 0 there, so everything should be gray. Now you see actually a gradient there. It's not gray. And this gradient is something that we want to find out and subtract from our data. So what do? We find the static tissue in our data set, and we also find the noise. We then fit a plane across the static regions and then subtract that plane from the phase different image. And then our velocity field in the static tissue should be 0. It's much easier if you do a phantom experiment. If you have a phantom experiment, you just can switch off your flow and you then subtract the flow off from the flow on phantom experiment. The next error source is, of course, the velocity aliasing. We learned a little bit from Sebastian that we actually use a Wenck setting, so a fixed velocity sensitivity for the acquisition of our data. So usually you set this Wenck to a value of the maximum expected velocity in your data set. If you do that, everything is fine. However, if your velocity is faster than your Wenck, you get velocity aliasing as illustrated in this little plot there. So what does it mean? You again get an error in your flow quantifications if you don't have the Wenck setting correctly or if you haven't corrected for aliasing. So this means, however, that what you also cannot do, you cannot just go arbitrarily high with your Wenck setting. Unfortunately, the Wenck scales with noise. So the higher your Wenck setting, the higher your noise. This means you actually have to really look and find out what your expected velocity would be. And there are several options how to do this. You could either run a Wenck scout before you do your velocity measurement. You could use information from an echo that you might have of your patient, or you can do a post-processing step that is called anti-aliasing. I don't want to go today into details because I only have 12 minutes. So what you do, you look at the neighboring voxels and then try to figure out if the voxel is aliased or not, and then correct for it. Usually this is done automatic, but if you have very narrow vessels, you actually might have to go in manually and correct it. Of course, there are much better ways to do it nowadays. There are also dual and multi-Wenck approaches. There's also the well-known method by Michael Löcher, the Laplacian method, that really works well. And of course, we also nowadays have AI methods that solve the problems. But I'll come to AI at the end of my presentation. So we already have seen that we can correct phase offset, anti-aliasing, and noise. The next step typically is the calculation of the phase contrast angiogram. Again, we have several methods of doing that. Some methods work well for intracranial, other work better for the liver, and the next work better for the aorta. And so there are several approaches, and I don't want to explain all of them. It's usually just a combination of velocity data, of the velocity numbers with a magnitude number, and then you somehow combine that, suppress the background, and then you get your angiograms as the one from Oliver, the brain, as well as an aorta example here. And nowadays, in the past, this is where we usually stopped. The phase contrast angiogram is what we use for the visualization and the quantification. Nowadays, because we are moving more and more towards completely automated analysis, we actually also have to do an additional step. We have to do a segmentation of our vessels. This can be done by just same old thresholding or region growing, like the standard image processing algorithms. A lot of people put some manual work in there and go there and paint single voxels through volumes, depending on how complicated the anatomy is. You actually might have to do this still. Or there are nowadays a lot of AI segmentation algorithms for the different anatomies. Harbin Behane has an algorithm for the aorta. Then there are algorithms for the different anatomies that we are applying for the flow. And tomorrow in the AI session, we will see more, for example, from Patrick, on automatic segmentation, also in disease, or in, for example, tomorrow then in brain aneurysms. So once you have the segmentation or the PC angiogram, you do the visualization. And there are several ways how you can do it. In some softwares, you can have a time-resolved velocity maximum intensity projection. That's quite easy, and it gives you a nice overview. You can also just use the vectors, or you can do a pathline or streamline approach for the visualization. And of course, the most important would be then the quantification of certain parameters. And as I said, unfortunately, I don't have much time to go each of those in detail, but there is, for example, a way to assess the vessel stiffness using the pulse or pressure wave velocity. This is pretty much the stiffness is the opposite of compliance. There are also several ways of doing that, but what is important to know that if you have a stiff aorta, you have a very high velocity, pulse wave velocity, and it goes up to, for example, 7 meters per second. Another important parameter that we will hear more about is the washer stress. It started, I think, in the late 2000 and between 2006 and 10, where the first algorithms came out that were based on 4D flow MRI. This is pretty much a value of how much the blood is dragging along the vessel wall. It has been found that, for example, in bicuspid aortic valve patients, because of the eccentric outflow, we have altered washer stress, and that correlates well, as we have seen also in Sebastian's talk. I have to hurry up, I know. So there are some examples of that. Relative pressure, I think we will hear more tomorrow, so I will go through this really. Not really go through this because I think we will hear more about it tomorrow. What I wanted to say, nowadays, we actually are relying more and more on AI. So in order to move things to the smaller vessels, for example, what a lot of people are doing is using super resolution, or we are using networks also to assess washer stress. So manual analysis of the data is a problem because it takes very long. but we want to be faster, we want to be reliable, we want to be reproducible, and hopefully adopt everything into the clinic. So I don't go through this, but automation is the key. And there was recently, let me go back actually, there was recently a publication by Ethan, who actually provided me these slides, where he plugged in all the different AIs for noise quantification, for anti-aliasing, for segmentation of facets. So everything was put together, and at the end it is only a button click to do everything automatically without much human interaction. And I think this is where we have to go, and this is how I think we have to try to bring this into clinical application.
Okay, Susan, sorry for cutting you off, but I got instructed that I have to be really strict. So
I know, I did that.
one conclusion?
Right. Thank you very much, and
Okay,
see you soon.
thank you. I'll hand over to my... I don't think we're going to do questions. I'm going to hand over to my co-moderator.
In the interest of time, we are moving forward. The next talk will be by Tekla Oechtering and is titled Go with the Flow, the Clinical Power of Flow Imaging. And unfortunately, Tekla won't be able to present in person, so this will be a pre-recorded video.
Thank you so much for this invitation to talk about the power of flow imaging in clinical routine. This is one of my favorite topics, and I'm looking forward to sharing it with you. I'm very sad that I cannot join you in Budapest in person, and I very much appreciate the opportunity to still contribute to this wonderful conference with this video. When you look at the spectrum of flow imaging, the clinical questions can be broken down to two simple ones. On the one hand, is there a stenosis? In other words, how fast is the blood flow? And on the other hand, there's the question for regurgitation or shunt. In other words, how much blood is flowing in which direction? These questions are being asked for the heart, for the large vessels, for cervical and intracranial vessels, and even cerebrospinal fluid flow. Eventually, I think we can answer them almost in the whole body. In this presentation, I would like to share typical and not so typical cases from our clinical routine when flow imaging was essential. Let's start with valvular heart disease. Here you can see a cine sequence depicting the morphology and motion of the left ventricular outflow tract, the aortic valve, and the ascending aorta. You can appreciate the dephasing jets in the ascending aorta indicating stenosis, and in the outflow tract indicating regurgitation. The question now is, how bad is it? To answer this question, we positioned a 2D flow plane through the sinuses of Valsalva, and we can see that the valve doesn't open and close properly. To quantify this stenosis, we're looking at the maximum velocity, which in this case is 350 centimeters per second. This number is needed for the stenosis grading, and it indicates moderate stenosis. Now let's look at the regurgitation happening during diastole. For this, we need the flow measurements, including the antegrade and retrograde flow volume. The regurgitation fraction, in this case 43%, allows grading of the valve insufficiency. And imagine that around 50% of ejected blood can regurgitate back into the left ventricle, and it is still only a moderate regurgitation. Our body is amazing. As you can see in this video, heart valves can move quite a bit up and down. This makes quantification of flow in a static 2D plane challenging. Some 4D flow post-processing software solutions offer retrospective valve tracking utilizing the 2D cine images, and this leads to higher quality measurements. These are the MRI images of a 61-year-old female, which was found to have right ventricular dilatation. MRI was ordered to find the reason for the dilatation, which could be an intra or an extracardiac shunt. On the left, you can see the short axis images of the heart. On the right, the long axis images. And you can appreciate that the right ventricle is significantly larger. than the left ventricle. To evaluate if there is a shunt, we measure flow in the main pulmonary artery and the aorta. Normally, the flow in both vessels should be equal, as they are two parallel circuits, the pulmonic and the systemic circulation. We measure 213 milliliters of flow in the main pulmonary artery. In contrast, we have measured only 93 milliliters of effective forward flow in the aorta. This means that there is 2.3 times more flow in the pulmonary system than in the systemic circulation. This ratio is called QP/QS, so flow in the pulmonary divided by flow in the systemic circulation, and it indicates a significant systemic to pulmonary shunt in this case. Now the question is, where's the shunt? Here you can see a coronal contrast-enhanced MRA on the left and a complex difference MRA from our 4D flow sequence PC Viper on the right. Both sequences reveal that the upper and middle right pulmonary veins drain into the right superior vena cava here. These vessels shouldn't be there. And this means that the oxygenated blood from the lung is going back over the superior vena cava, back into the right heart, and then again to the lungs. And this needs to be surgically treated. The next patient is a 25-year-old female with bicuspid aortic valve with regurgitation and an ascending aortic aneurysm. The MRI was ordered as a routine follow-up. Again, the short axis is seen on the left and the long axis CNAs are seen on the right. In this patient, both ventricles are normal size with normal function. There's a small aortic regurgitation jet seen on the 3-chamber view here. As the size of the regurgitation jet can vary with varying TE and plane placement, the size does not allow the grading of the regurgitation. That's what we need the flow measurements for. In this case, we positioned our 2D plane at this level of the sinuses of Valsalva. Using 2D flow, we measured 100 milliliters of forward flow and 50 milliliters of backward flow in the sinuses of Valsalva. This corresponds to a regurgitation fraction of 50%. That would be a moderate regurgitation. However, the left ventricular stroke volume was measured at 150 milliliters. Where are the missing 50 milliliters of blood? Let's check the 4D flow. Unfortunately, there was aliasing in the sinuses of Valsalva due to the flow acceleration due to the mildly stenotic bicuspid valve. That's why we couldn't do the 4D flow measurements in the same plane as the 2D flow measurements. That is why we measured the flow in the ascending aorta. The measurements were roughly the same compared to the 2D measurements in the sinuses. However, there was pronounced helicity, and I wasn't sure if I could trust those measurements because of that helicity. So I chose a plane in the distal ascending aorta with less helicity. However, the flow there was also roughly similar, so there was a low effective forward flow. It must be real. Surprisingly, the flow in the main pulmonary artery was 130 milliliters, which roughly correlated to the right ventricular stroke volume. So maybe our measurements of the ventricular stroke volume of the left ventricular stroke volume was wrong. We placed another plane in the left ventricular outflow tract and measured 142 milliliters of forward flow, which roughly corresponds to the left ventricular stroke volume. Interestingly, there was only 8 milliliters of regurgitant flow correlating to a regurgitation fraction of 6%. And this also better correlates to the small regurgitation jet. To summarize our findings so far, there is mild aortic valve regurgitation when measured in the left ventricular outflow tract. The QP/QS is 2.3, indicating that there's 2.3 times more blood flowing through the pulmonary circulation compared to the systemic circulation. The left side loses about 50 milliliters of blood somewhere between the left ventricular outflow tract, and the sinuses of Valsalva. Let's have a closer look at the scene images again. There's a weird linear artifact from the right coronary sinus to the right atrium or ventricle. And this indeed is our shunt. This patient had a spontaneous right sinus of Valsalva rupture into the right atrium. Interestingly, the note in the chart from the follow-up clinical visit after the routine MRI read as follows. 4 weeks ago, her Apple Watch showed that her heart rate jumped from the 60s to the 90s suddenly. Since then, she has felt slightly winded with exertional activities. So although the jet was visible in the scene images, the flow images tremendously helped pinpointing and understanding the pathology. Here's a more typical case of how we use flow imaging in clinical routine. This patient has complex congenital heart disease, and to understand the flow distribution and potentially needed intervention, we require lots of measurements in many different vessels. Doing this with 2D flow MRI is cumbersome and time-consuming. In many hospitals, it's typically the attendings who spend 10 to 20 minutes at the scanner for the plane placement. This can be done much faster with 4D flow MRI in one sequence that covers the anatomy and the flow in the entire volume. This is the last case. A 9-month-old girl with complex congenital heart disease status post-repair. Her pulmonary arterial blood flow completely relied on a small surgical shunt from the ascending aorta to the pulmonary arteries. Neither the contrast-enhanced MRA on the left nor the T1 FATSat were able to show this shunt. This would mean immediate surgery for the patient. However, the complex difference MRA from our 4D flow MRI sequence showed a widely patent shunt. We believe that it was a combination of spatial resolution and artifacts, for example, from sternal wires, that prevented the visualization in the conventional MRI sequences. Let me conclude. The power of flow MRI lies in the diagnosis, quantification, and follow-up of stenosis, regurgitation, and shunts. This is true for both 2D and 4D flow MRI. The additional power of 4D flow MRI is that we can acquire an entire volume in one single acquisition with high internal consistency. We can retrospectively analyze vessels in the entire volume, and we can optimize plane placement to avoid artifacts or pronounced helical flow. Don't forget to look at the complex difference angiography, which can provide valuable information. I have not talked about the many new and advanced parameters that have not found their way into clinical routine yet, such as kinetic energy or wall shear stress, to name just a few promising parameters that will come in the near future, I hope. I thank you very much for your attention, and I'm happy to take any questions via email.
Okay, so now we are at the end of the educational session, and the second half will feature the scientific talks. And the session will be moderated by Ethan Johnson from Northwestern University and Hildo Lamb from the University of Leiden.
All right, thank you, Patrick and Pim. Since we're running a little late, let's just jump in with our first presentation from Jia Xiang from Yale University.
Thanks for the kind introduction. I'm Jie Xiang. I'll share our recent work on 4D flow BSS-FP at clinical fields. This work is supported by AHA pre-doctoral fellowship. The conventional 4D flow has limited contrast that leads to the use of contrast agents and additional BSSP CNE scan. However, there have been some studies that has successfully combined the 2D phase contrast with the BSSP into a single scan so that they have a better flow imaging. And including our recent approach that we have the fully balanced gradients in all the X, Y, Z 3 directions, and we add bipolars to encode the flow in one direction. And most importantly, what we found is that we have to add extra bipolar at the end to now the first moment, without which the velocity will be wrong. And we tested our method at 3 Tesla for in-plane flow. And you can see this is a standard phase contrast with a GRE contrast. With our method, we can show much better myocardial tissue and the blood contrast. And also we show the accurate flow measured, the accurate in-plane flow. We also tested this one at 0.55 Tesla for through-plane flow. So in this case, we encode flow in the Z directions and adding this bipolar to now the first moment as well. And compared to a 2-minute average scan at 0.55 Tesla, our method can show much better improved image quality and in a single breath-hold, and also the accurate aortic flow measurements. So based on our previous experience with the in-plane and through-plane velocity encoding capability, we aim to extend our previous method to be a 4D flow version. That means we want to encode the flow in all the 3 directions, X, Y, and Z. So we have to allow the first moment in X, Y, and Z. This implementation has been done by McGrath at 0.6 Tesla as well, but this has never been tested at a clinical field, which has some additional challenges like higher SAR, the stronger off-resonance artifacts, and also the steady-state disturbation. So how can we address those problems at clinical fields? And this is our basic sequence we have for the 4D flow at 3 Tesla. So we have the first moment now at all the X, Y, and Z directions, and the flow encoding at TE. To reduce the SAR, we only acquire data during the end expiration. And for the rejected heartbeats, we turn the RF off so that we can have about 50% of SAR reduction. For the second problem of the strong off-resonance artifacts, we try to shorten the TR by using a very strong asymmetric echo. Because of this asymmetric feature, we have to design the bipolar gradients to encode flow at T and the bipolar gradients to now the first moment and the TR individually, because it's asymmetric. For the steady-state preparation, we have added extra alpha over 2 pulse for each heartbeat to accelerate the steady-state approaching procedure. So we first tested our method in a phantom study. The top row is from the 4D flow GRE, the standard methods, and the second row is from our method. You can see much better SNR, and we compare the velocity measure in all the 3 directions, X, Y, and Z. They show very strong agreement. I also want to show that without any alpha over 2 preparation, we have very strong artifacts from the 4D flow BSSP. So we have to use some preparation. We use navigators. And then we conduct in vivo experiments at 3 Tesla and 1.5 Tesla with 13 healthy subjects. But the basic idea is we want to validate the flow velocity and the flow volume measurement versus standard 4D flow GRE and the 2D evaluation. For the flow velocity, we simply get the maximum velocity from the blood pool, and we compare that with the 4D flow GRE and the 4-chamber 2D phase contrast. And for the flow volume, we got the total volume through the mitral valve plane and compare that to a standard 2D aortic flow images. So this is a static view from the top row is from our method 4D flow BSSP versus the standard GRE. You can see across the different slices and across the different cardiac phases, we have much better or improved myocardial tissue blood contrast, especially during the end of diastolic stages, there is no inflow enhancement. The standard 4D flow GRE show no contrast at all, but our method maintain the high contrast and also the high accuracy of the flow measurement. And these are some movies we show using our 4D flow BSSP versus the GRE. And this is showing different slices indicated by these red yellow lines. You can see the first top row is the GRE. There is almost no contrast at all during the late diastole, but we have much better visualization using our method. And this is showing all the 3 different velocity encoding direction. And the nice thing is that because we have this nice BSSP phase contrast, we can do a pseudo 4-chamber or 3-chamber view where we can see the diastolic inflow and also the outflow track into the aorta. And we do not have to acquire another 3D BSS Cine because the magnetic images from 4D flow is great for the overlay. And we do not have the issue for the image registration, etc. And statistically, we compare the flow velocities, where you can see our 4D flow BSS show very strong agreement with the 2D evaluation and the 4D flow GRE version. They show very similar measurement of E and A, the peak velocity. For the flow volume, we also show the strong agreement with the standard 2D aortic measurement and the 4D flow GRE. So we basically validated our method versus the 2D and 4D flow GRE for the flow velocity and the flow volume. These statistical analysis were based on 3 Tesla, but we also have 1.5 Tesla validation. And this is one example. You can say the top row is the 4D flow GRE at the early diastole and the late diastole. You can see there is no contrast at all. But with our method, we maintain this high blood tissue contrast across the whole cardiac cycle, and we show the similar flow measurement. Especially, you can see much better visualization of the pulmonary artery, like all the different chambers and the pulmonary muscles. Those features cannot be visualized by the 4D flow GRE methods. So in conclusion, we proposed to 2D phase contrast first, and then we extended that to be a 4D flow version, and we validated this method on the 2 most commonly field strengths, 3 Tesla and 1.5 Tesla, both in infinite and in vivo experiments, showing the similar flow velocity and volume measurement, and much better contrast versus the 4D flow GRE, showing its potential for a more robust tool in diastole function evaluation versus 2D. Thanks for your.
Thanks for that very nice presentation. Do we have any questions for the speaker?
Well, thanks a lot. Great work, indeed. Just had one technical question. How do you interleave the various directions? Do you scan the entire K-space for one direction and switch to another? Or do you do it sort of beat interleaved?
Thank you, Sebastian, for this good question. So we have because we know the first moment in order for each TR at the end of TR. So it doesn't matter that we can do both. So like we can acquire all the reference scan together first, and then do the second, the third or fourth velocity encoding, or we can interleave them. In this case, we are doing the interleaving application.
I mean, in terms of interleaving, have you seen some unsteady problems? Because as you switch the gradients, right, so you get into a different steady state, and then you see some artifacts. I thought I saw them in your slides, but maybe it's good to sort of interleave differently, right? So essentially scan an entire direction first and then switch to the other. Yes,
I believe, because actually before the 4D flow, we tested the 2 different scanning strategy on the in-plane flow. We do the interleaving or separating, acquiring them separately. I feel like if we do the separately, it's like probably better for the eddy currents, like because they are in different gradients. But somehow if we separate them, there might be like some flow, like some motion artifacts or some extra problem.
Yeah, I mean, you have to deal with that and in recon, right? But that's a separate.
Yes, yes.
Okay, thanks. Great talk.
Thank you.
I think we'll have to move on.
Yeah, thank you very much. Other questions, of course, you can ask directly during the coffee break. We proceed with the next presentation on improved 5D flow MRI with 3D ring gradient delay correction. That is presented by Dr. Tara Nalamoto. She's from Northwestern University in Chicago and a graduate student.
Okay, yeah, thank you so much. 5D flow is a free-running, free-breathing flow-encoded sequence that gives you flow over 3 dimensions and also the cardiac cycle and the respiratory cycle. This is enabled for our purposes with self-gating and 3D radial golden angle sampling. And the use of this strategy allows us to arbitrarily subdivide K-space into these multiple motion states. But one issue that can arise with radial sampling is gradient delay errors, where the delay between the actual versus the planned gradient timing results in a shift in the actual encoded K-space position. And this is especially problematic in radial sampling because you must cross the center of K-space many times, and a delay can cause a misidentification of the K-space center. And so one strategy for correcting this is to simply shift the center of each spoke back to the K-space center by either moving the peak of the K-space spoke or by aligning anti-parallel spokes. But it has been shown that gradient delays in both the X and Y gradients can cause not only a parallel shift in the spoke, but also an orthogonal shift that can't be accounted for if you use a one-dimensional correction. And so Ring is a gradient delay correction method that was published a few years ago that actually accounts for 2D shifts in K-space spokes by modeling these shifts as an ellipse. And so the shift in K-space for each point is defined as a vector that is a function of the sampling angle and this shift matrix S. And the way you solve for this matrix is by fitting the model to the intersections between orthogonal K-space spokes, where the intersection is the point where the two spokes are approximately equivalent. And so this is a self-calibrating approach, and it works very well in 2D. And the way that you would apply that to your data is to compute these K-space shifts, like the shift vector, and then apply that to the trajectory. And so then use that modified trajectory in your reconstruction. And so for us to use this approach for 5D flow, we just simply implemented it in 3D by modeling the K-space shifts as an ellipsoid instead of an ellipse. And then we applied the correction. We computed the correction using the reference encode and then applied it to all of the velocity encodes as well. And so even though the artifacts that can arise from radial gradient delays can be accounted for using compressed sensing, the actual impact of those delays on the phase is not really well characterized. And so the point of this study was to quantify how a 3D ring gradient delay correction versus a 1D shift correction actually impacts both the magnitude image quality from 5D flow data and also the resulting computed velocities. And so we tested both these reconstruction methods in 5D flow data that was collected in 10 volunteers. And a way to understand what this is doing in K-space is to look at this one example. This is a plot of the K-space magnitudes over the original trajectory on the left and then the modified ring-corrected trajectory on the left. And what you can see is that the weight of K-space is clustered more towards the center of the image with the correction, which indicates that this is in fact a good fit for our data. And so we look at the image quality and the magnitude data by computing a fully sampled time average, non-compressed sensing magnitude image. And we saw that there is improved image quality with 3D ring and actually degraded image quality with a 1D shift correction. And there's a significant increase in the signal within the body versus the signal outside of the body with this correction across the data set. And so to look at how this actually impacts the computed velocities, we did a time resolved compressed sensing reconstruction and looked at aorta flow over just expiration and over the cardiac cycle. We saw that the time curves of aorta flow didn't really change much with the trajectory correction, but there was interestingly a decrease in the peak velocity in the ascending aorta. And so you can see that in this example here, the 3D ring corrected data is in the middle, and there is a decrease in the ascending aorta peak velocity, but the majority of the changes did happen around the edges of the image. But also interestingly, the decreased ascending aorta peak velocity actually looked more similar to what we saw in 4D flow in the same subjects. And overall, the 4D flow data had significantly decreased ascending aorta peak velocity compared to the uncorrected 5D flow data, which leads us to believe that the velocities obtained with this correction are more accurate because they are more similar to the Cartesian flow. So we saw that this gradient delay correction does significantly reduce artifacts in 5D flow magnitude data, and it does significantly impact the quantified velocities. And we believe that a 3D radial gradient delay correction like Ring should be used when you're looking at radial flow. But we still need further validation in comparison with other Cartesian ground truth methods. Thank you to everyone in my lab and my collaborators.
thank you very much. So open for a discussion. You go ahead first.
Yeah, okay, so the whole correction is fit within the center 1.5% of case space. So it's quite small. It's less than 1 voxel of a difference.
To my understanding, you are using this ellipsoid fit to do a retrospective correction of your reconstruction. My question would be, is there a plan to implement these shifts into the measurement so the gradient delays don't happen in the first place?
We have no plans to do that at the moment, but you could probably perform a similar correction using GIRF prospectively. Yeah.
Hey, great talk. So I just wanted to hear your thought on whether it's only a first order problem, right? I mean, you just correct delays, right? But there could also be eddy current issues of second order, for example, right? So is that something you find negligible, like higher order terms?
No, I haven't thought about how to correct for higher order terms, aside from what we already do in the like eddy current corrections with the third order polynomial fitting. And this does, so the data that I showed, we did perform that correction as well. So this is getting at things that cannot be corrected using that third order polynomial, but no, I haven't thought about how to move beyond the case.
Any other questions? If not, then we proceed with the next presentation.
All right, thanks again. So we'll go on now to Stefan Gerke from University Hospital Basel.
Thank you everyone for joining me today. My name is Stefan Gerke. I'm here to present to you our study titled A Comparison Between MRI-based pulmonary flow measurements, 2D phase contrast, 4D flow, and lung perfusion using matrix expansive decomposition. This work was conducted at the University Hospital of Basel. I have nothing to disclose. So let's start with some context. There are various non-invasive. All right, I should probably just start with the microphone on. Okay, so, but I guess you heard me anyway. So there are various non-invasive MRI techniques that exist to evaluate the pulmonary flow, but the implication of the differences between these methods are not fully understood. The purpose of our study was to evaluate the agreement in cardiac output measurements derived from 2D phase contrast, 4D flow, and lung perfusion using matrix expansive decomposition, which I will abbreviate as QMP throughout this talk for simplicity. So we conducted a prospective study involving 10 healthy volunteers aged between 20 and 35 years old, with an equal split of 5 males and 5 females. Flow measurements were taken in the main pulmonary artery, 1 centimeter downstream from the pulmonary valve, using both 2D phase contrast and 4D flow MRI. Lung perfusion was assessed using matrix expansive decomposition. Time-resolved sets of coronal images were acquired using ultrafast balanced steady-state free precession sequence in free breathing. So our images, the 2D phase contrast images, were analyzed using CVI-42 by a cardiothoracic radiologist with 5 years of experience. The 4D flow images were analyzed using Sud Hart by a fellowship-trained cardiothoracic radiologist with 2 years of experience. And functional lung data acquired with ultrafast balanced steady-state free precession were analyzed using a fully automated image processing pipeline called TrueLung. All data acquired, all cardiac output measurements were reported in milliliter per minute. So first we checked the data for normal distribution and reported it as median and interquartile range. Then to compare the methods, we used the Friedman test to assess the differences across the 3 techniques. Pearson and Bland-Altman plot were used to evaluate the pairwise correlation and agreement. Now let us dive into the results. The Friedman test showed no significant differences between the methods with a p-value of 0.9, indicating comparable performance overall. The mean, did I go back? Sorry. Can you go a slide back? Sorry. All right. So thank you. The median cardiac output values were 6,500 milliliter per minute for 4D MPA, 6,800 milliliter per minute for 2D MPA, and approximately 6,200 milliliter for QMP. The absolute differences were highest between 4D MPA and QMP with 840 milliliter per minute, followed by 2D MPA and QMP with 640 milliliter per minute, and the smallest differences were observed between 2D MPA and 4D MPA with approximately 500 milliliter per minute. Now I'd like to go through a pairwise comparison between the three methods, starting with 4D flow versus QMP. On the left, the Pearson plot indicates a moderate correlation of 0.71 with some scatter along the trend line, whereas the bland Altman plot on the right showed a mean bias of minus 76 milliliter per minute, with limits of agreement between minus 2,000 to plus 1,800 milliliter per minute. Moving on to the next pair, 2D phase contrast versus QMP. The Pearson graph on the left displayed a strong correlation of 0.81, with points closer aligned along the trend line. The bland Altman plot on the right demonstrated a mean bias of 186 milliliter per minute, with limits of agreement between minus 1,200 milliliter per minute and 1,600 milliliter per minute. The last pair we looked at was 2D phase contrast and 4D flow. The Pearson graph on the left shows a very strong correlation of 0.94 with data points tightly clustered along the trend line, whereas the bland Altman plot on the right showed the mean difference of 263 milliliter per minute with limits of agreement between minus 680 milliliter per minute to plus 1,200 milliliter per minute. In conclusion, our findings indicate a strong correlation and a good agreement between the three methods. The largest differences were observed between 4D flow and QMP. However, the 2D phase contrast showed better agreement with QMP than 4D flow did. Why does this matter? Unlike 2D phase contrast and 4D flow, which measure flow only in the pulmonary arteries, the lung perfusion also captures the blood volume from the bronchial arteries. The normal bronchial flow is approximately 3 to 4% from the total cardiac output. However, conditions like chronic thromboembolic pulmonary disease can increase the flow through the bronchial pulmonary anastomosis up to 30% of the total cardiac output. Our studies suggest that by combining 2D phase contrast or 4D flow with lung perfusion, one can determine the blood flow in this bronchial pulmonary anastomosis. So thank you for your attention.
Thank you for the nice presentation. Do we have any questions? I'll go ahead and get things started. So I noticed you used a few different analysis programs for the different modalities or acquisition methods. Could you comment? Was it a matter of convenience, or were there other reasons that you chose CPART or CVI42?
Yeah, sure. Thank you for the question. We had some logistical problems. We only were able to use CVI42 for a limited period, and then we had to switch to Sweetheart program.
And then, do you think that this evaluation needs to be expanded into other types of subjects, disease states?
Of course. So we only have 10 healthy individuals. We definitely need a larger cohort to validate this study. And then we should further look into pathological conditions to see if our assumptions are true or not.
Great, thank you. If there are no other questions, I think we'll thank you again and move on.
Next presentation. Next presentation is on high temporal resolution pulse-gated single VENC compared to EKG-gated dual VENC 4D flow MRI, and then applied for intracranial hemodynamic assessment, presented by a postdoc from Northwestern University in Chicago, Anahita Najaf.
Thank you for the kind introduction. Here are my disclosures. So cardiovascular risk factors are linked to cognitive decline, but the underlying mechanisms are unclear. 4D flow MRI and neuroimaging enable a comprehensive evaluation of this association, but they're typically acquired in separate exams, and acquisition within a single 1-hour imaging session is quite challenging. So our lab had previously developed a single session heart-brain MRI protocol using dual wing 4D flow MRI with prospective ECG gating for intracranial flow imaging with a short scan time. And it proved successful in the preliminary investigations, but this particular implementation was not designed for high temporal resolution, about like 40 milliseconds, or retrospective gating. And in our initial test, the ECG triggering for retrospective gating of intracranial 4D flow proved challenging. So we aim to use an alternative sequence with high temporal resolution single bank approach and retrospective pulse gating, and compare it with the previous sequence DV-ECG in the velocity noise and hemodynamic quantification. So we recruited and scanned 11 mid to late life cognitively asymptomatic adults, but one was excluded due to ECG signal loss during the DV-ECG acquisition. So we ended up analyzing 10 participants with the mean age of 65.5, 8 females, and 5 with hypertension, and 5 controls. Here is a summary of the sequence parameters. They were both acquired at 3 Tesla with 1 millimeter isotropic spatial resolution. You can see the difference in temporal resolution, and the wings were set at 60 and 120 for the dual wing and 120 for the single wing. Acquisition time was comparable between the two sequences, and they used different acceleration methods and factors. Here is a pipeline of how we calculated the velocity noise. So the DICOMs were, the unprocessed DICOMs were used for static tissue segmentation, and velocity noise was calculated as standard deviation of static tissue velocity over time. And this is the semi-automated quantification pipeline. So the data went through the standard pre-processing steps and manual segmentation. Because of the pulse gating in the high-res SV pulse sequence, we did automated time delay correction, and a voxel-wise hemodynamic mapping quantified the hemodynamic parameters. Here is the result of the velocity noise and its comparison between the two sequences. As we expected, the high-res SV pulse had higher velocity noise. Here is velocity waveforms of the cases. On the left is an example case comparing the velocity waveforms of the two sequences. You could see that the single bank approach could capture sharper systolic peaks and pulsatile waveforms. And on the right, you can see the waveforms across the entire sample. Looking at mean velocity over the entire cardiac cycle, there was minimal non-significant bias between the two methods, as you can see on the Bland plot on the right, and moderate correlation between the measurements. But for systolic mean velocity, there was a significant bias with high-res SV pulse quantifying higher measures and moderate correlation. Same for maximum velocity. High-res SV pulse could captured higher max velocities, and the two methods didn't agree. For pulsatility index, we used a voxel-wise approach, and high-res SV pulse captured higher values, but the measurements were not correlated. And for time to peak, there was minimal bias, but relatively wide limits of agreement and moderate correlation between the two methods. So in conclusion, HIRA's SV pulse intracranial 40 flow sequence within the heart-brain protocol was acquired and captured higher systolic velocities and pulsatility compared to the DV-ECG 40 flow sequence, but there was higher velocity noise also. Our results show that there we need to be cautious when pulling or comparing results from different studies that use different sequences. HIRA's SV pulse was useful for time-limited flow imaging within heart-brain protocol because it could address scan time and temporal resolution trade-offs and limitations of prospective gating. However, we had some limitations in the DV-ECG acquisition. The MRI technologist was quite conservative in selecting the timeframes, and we did not do extrapolation of data to diastole. Our next steps would be to compare these measurements with 2D phase contrast MRI. And future directions could focus on development of high temporal resolution dual wing 4D flow sequence with retrospective gating and short scan time. Thank you for your attention.
Thank you very much. Paper is open for discussion. Any questions from you? Maybe I guess I missed it, but maybe you can repeat. What was the temporal resolution for both the techniques you compared?
So the dual wing method had a temporal resolution of 80 milliseconds, but the single wing had 40 milliseconds, and we kind of wanted it to match with the cardiac 40 flow for our heart-brain imaging protocol.
So 40 milliseconds was the shortest time?
Yeah.
Because do you consider that as high temporal resolution? Because
I wouldn't say
doubt about
that's a high temporal resolution. What I meant was like compared to the other sequence, it had like higher temporal resolution, but you're totally right. Yeah.
And what resolution do you desire? What is the optimal temporal resolution for these, for example, pulse wave calculations or other distensibility measurements?
I think between like 30 to 40 would be good enough. And because we're looking at heart-brain hemodynamic coupling, it's important for us that their temporal resolution is quite similar.
Right. Thank you very much. Any other questions? If not, then we proceed with the next.
All right. Thank you again. And let's please welcome our next speaker, Jiachun Liu, who will present quantitative evaluation of temperature-induced vessel changes using 3D PC-MRA, a 5 Tesla MRI study.
Thanks for your introduction. And I'm Jiachun Liu from Tsinghua University. And today I'm going to introduce our recent study on quantitative evaluation of temperature-induced hand vessel changes in systemic sclerosis using three-dimensional phase contrast MRA. And systemic sclerosis, or scleroderma, is a rare autoimmune disease. Combines vasculopathy, immune cell activation, and fibrosis. Although skin thickening is a hallmark of this disease, the chronic inflammation may also lead to multi-organ damage. And the high heterogeneity and multi-organ involvement complicates the clinical healthcare and progression management. The hand is the very first and infected region in renal phenomenon, which is cold or stress-induced vasospasm, is the early hallmark of the systemic sclerosis. Therefore, measuring temperature-related hand vessel changes may help reveal vasculopathy in systemic sclerosis patients. MRI is sensitive to evaluate the early manifestations of systemic sclerosis patients and has been widely used in multiple organs of the disease. Studies using MRI has confirmed that there indeed have some vascular involvement in systemic sclerosis patients. However, no study have directly evaluated the temperature-induced changes among these patients, and there is no proven that the response to temperature differ from the healthy controls. Therefore, this study, we aim to evaluate the temperature-related hand vessel changes in systemic sclerosis patients. We use three-dimensional phase contrast MRA for imaging and to conduct this study. The 3D PCA has been confirmed to have boosted SNR in ultra-high field scanners and allowing the sub-millimeter depiction of small vessels. The key parameters are listed below, and to generally speaking, we achieved a 0.6 millimeters isotropic resolution acquisition and 0.3 millimeters resolution isotropic after recon. The single scan was completed within 5 minutes, and the scan was accomplished with a superflux body coil wrapping one hand with patient in a Superman position. And to evaluate the temperature-related changes of the hand vascular, we scanned all participants twice. At the first time, we just scanned them under the room temperature of about 20 degrees Celsius. After that, the same hand took a 5 minutes warm water bath at about 40 degrees Celsius, and then for the second scan. And here's the illustration of the image analysis of the three-dimensional phase contrast MRA images. And this is, we propose a semi-automated pipeline for the post-processing. After a manual ROI selection, the vessel structure and the hand volumes were calculated automatically from the angiogram and magnitude images. And to make the features comparable, we further normalized the total volume, total length, and mean radius of the hand vessels using the hand volume. And to evaluate the temperature-related changes, we also calculated the relative changes of the features. And we recruited 22 systemic sclerosis patients and 10 controls for this study. And pair samples t-test was used for comparison of vascular features before and after warm water immersion, and non-winding U-test or independent t-test for group comparison of relative changes of vascular features. And here's a representative illustration of the results. And on the left is a image of a 62 years old systemic sclerosis female patient, and on the right is an age and sex matched control. It's apparent to see that systemic sclerosis patients have a less abundant vessel structure when compared with the control. After 5 minutes warm water bath, the imaging of the vessel is apparently improved, yet it's still rare. Also for the healthy control, warm water bath improves the imaging of small vessels, especially in the fingers. Here's a statistical comparison of the features. Both patients and controls exhibit increased volumes and lengths of hand vessels, but there's no significant difference in mean radius of the between groups. Also, notably, systemic sclerosis patients demonstrated significant exaggerated response to thermal stimulation. And this is the conclusion. First of all, the three-dimensional PCMRA is efficient for capturing hand vascular features within 5 minutes. A warm water immersion significantly increased the volume and length of hand vessels. Also, the systemic sclerosis patients are hyper-responsive to temperature. And there still exists some limitations concerning the relatively small study sample and simplified post-processing. In the future, we're gonna perform more exploratory analysis about the intercorrelations between the hand vessels and vasculopathy of other vascular beds and other clinical outcomes. And special thanks to my colleagues at Tsinghua and rheumatologists at Peking Union Medical College Hospital. And thanks for your attention.
Thanks for that nice presentation. Do we have any questions from the floor? We have a question in the middle here. Sir?
Oh yeah, it was 3 centimeters per second. Well, actually, they're in this lysings, but we want to have a higher sensitivity to slow flows at the hand. The flow itself is relatively slow, so to have a better imaging of the angiography, we set a relatively low Wink value. Well, not yet. So that's why we don't have a value of the velocity here. Yeah, we're gonna do it in the future work.
And if I understood correctly, you don't have any temporal component to your measurement, correct? It's simply one time point, and that's because you don't expect a lot of pulsatility in the hand, or some other reason?
Yeah, we don't have temporal.
Do you think there would be value in actually potentially tracking, say, as you put the hand in the water bath, what the change is?
Actually, I think there will be some help, but you can see that now the position of scan is the Superman position is not so comfortable, and a 5-minute scan is a present scan, a 5-minute scan. We can see some patients may not suffer from a steady state, and they may move and cause some motion corrections, motion artifacts. So if we add some temporal resolution to have more temporal states, there may be significantly increase the scan time, and maybe it's difficult to correct for the motion artifact.
Okay, so a bit of a logistical challenge. Thank you again, and we'll move on to the next section of this session.
Yeah, now we will switch to the power pitches, only 3 minutes each. So we have to pay close attention not to miss all the details. So go ahead with the first pitch.
Hey, thank you very much for the introduction, and I'm happy to present to you the first results of our study on the interaction of aortic hemodynamics with myocardial and vascular remodeling in symptomatic and asymptomatic aortic stenosis examined by 4D-Flow CMR. So I have nothing to declare. As you all know, aortic valve stenosis is the most common valvular heart disease in Europe and North America, and we heard a lot about it today from Professor Kutzerke and other speakers. However, a subgroup of these patients with severe stenosis is asymptomatic. Approximately 50% of these patients when presenting first to their referring physicians. And with the severe symptomatic patients, it's easy. We send them to surgery, either interventionally or through open heart surgery. But what do we do with the asymptomatic ones? Do we watchful waiting, or do we send them early to surgery? And in the current guidelines, this is highly controversial. So we thought about applying 4D-Flow CMR in these kind of patients to examine if there's a difference to the symptomatic ones. So therefore, we performed a prospective multi-site study where we included moderate and severe aortic stenosis patients, either symptomatic or asymptomatic, and scanned them at the Berlin Research Network for CMR, which is an infrastructure across the different campuses of the Charité in Berlin, where we can perform comprehensive CMR at different scanning sites or at research scanners of the same vendor, F3 Tesla. As a control group, we included a retrospective cohort of healthy volunteers as a control group and performed a multi-parametric CMR, including 4D-Flow CMR. We looked at maximum wall shear stress at different planes of along the aorta. Here are the results. We included 22 symptomatic, 20 asymptomatic, and 19 healthy volunteers in our cohort. There were no differences in ventricular function, focal fibrosis, and LGE or aortic orifice area between the stenosis groups. However, symptomatic aortic stenosis revealed higher wall shear stresses in the ascending aorta and also in planes 4, 5, 6, and 8, meaning the aortic arch and descending aorta than asymptomatic ones. Interestingly, there were significant differences between symptomatic and asymptomatic stenosis compared to healthy volunteers, whereas healthy volunteers revealed higher wall shear stresses in plane 5, 6, 7, 8, and 9. And coming to the conclusions, symptomatic aortic stenosis had higher wall shear stresses in the ascending aorta compared to asymptomatic ones. However, in the later aortic arch and descending aorta, volunteers showed higher wall shear stresses than both aortic stenosis groups. So we think there's a potential role of 40-flow CMR and risk stratification in these patients. And now we're currently analyzing advanced and other parameters of 40-flow. And if you'd like to discuss it with me, I'm happy to see you at the e-poster. So thanks a lot for your attention.
And our next speaker will be Regan Tompkins, presenting foramen ovale shunt for visualization and quantification using particle tracking and 40-flow MRI in normal fetal hearts.
Thank you. So yes, 40-flow MRI can provide valuable insights for elusive diagnoses in severe congenital heart disease in the fetus. However, it has been shown to be quite challenging, namely the high spatial and temporal resolutions that are required, but also the large amount of motion that can potentially occur during the scan. So as we look to develop our strategy for 40-flow MRI with motion correction, we have to ask ourselves, what exactly can we resolve? What are the limits to what we can visualize with 40-flow? And a good test case for this is the foramen ovale, which is a critical shunt between the two atria bypassing the pulmonary circulation. And it's a small hole that experiences complex flow in that the oxygenated blood coming off of the placenta and the mother travels through the ductus venosus and preferentially shunts across the foramen ovale into the left side of the heart, while deoxygenated blood from the inferior vena cava largely remains on the right side. So we wanted to see if we could observe this phenomenon using our 40-flow technique in utero. And so we used our Amsterdam-developed pseudospiral acquisition scheme with continuous sampling, which allowed us to then retrospectively correct our data for maternal motion, maternal breathing motion, and random fetal movements. And we looked at 5 healthy data sets of fetal hearts in their 3rd trimester, acquired by our collaborators in Denver. And in each of these data sets, we took into GT-Flow and located our 2 vessels of interest, the ductus venosus and the distal IVC, as well as the foramen ovale. We placed contours over them, and we seeded particles at these vessels at each cardiac phase for 2 cycles, and then measured the arrivals of these particles at the foramen ovale. And when we did this, we observed foramen ovale flow in all 5 of these cases. As in this example, we saw a higher percentage of these red particles from the ductus venosus pass through the foramen ovale, which indicates that this oxygenated blood is prioritized to the systemic circulation. This wasn't observed in the final case, perhaps due to residual fetal motion. But this is the key. Of course, we want to push this resolution and play that game, but what we ultimately see in image quality will be dependent on our motion correction technique, especially in the case of longer scans. So this is a good measure of how that is advancing and how we're doing with that technique, but it's also revealing of the capabilities of in utero 40-flow MRI, and seeing oxygenated blood in this way is unique to this technique. And it opens the door for how we can study and characterize abnormal flow in fetal CHD. Thank you for your attention.
All right, thank you very much. It's always pity that it's very short, these pitches. We proceed with the next presentation by Jessica Smith on convolutional variations for computationally efficient training of spatiotemporal super resolution 40-flow MRI.
Thank you for the introduction. A 40-flow MRI provides a full view flow mapping over time, but the trade-off between acquisition time, noise, and resolution is clinically challenging. To increase the resolution post-scan, deep learning has emerged for super resolution tasks, mainly either in spatial or temporal erection. An extension to a combined spatial-temporal super-resolution, especially in the convolutional setting, is largely unexplored due to the computational complexity. Thus, we aim to develop a computationally efficient convolutional neural network for spatial-temporal super-resolution and denoising of 4D-Flow MRI data. As a base architecture, we use the pre-existing residual network for spatial super-resolution called 4D-FlowNet. But as we additionally want to include temporal information, we have to be able to handle 4D input data. Thus, we need to exchange the 3D convolution with more computational complex 4D convolution. In our work, we evaluated 6 different higher order convolutions, going from a baseline 4D convolution to computational more efficient modification, like a breed or sparse convolution. We test our setup with scientific generated data of 6 different CFD models. On the top left, you can see the spatial and temporal downsampled noisy low resolution derived from the high resolution image, which we use to feed our networks. As you can see below, all our models are able to predict a prediction which is similar to the high resolution image. The quantitative analysis even show that our modification even increase the accuracy. The convolution modification led to a substantial reduction in computational time. With the sparse and the combined nested 3D and 3+1D convolution achieving the best results in the accuracy and also even enabled a 6 times speed up in training time compared to the baseline model. To summarize, we achieved a computational efficient spatial temporal super resolution of 4D-Flow MRI, meaning that we are simultaneously increase the spatial and the temporal dimension. Our efficient modification led to a substantial speed up, resulting in comparative training and inference time. Ongoing research even indicate that including spatial temporal information can lead to improved accuracy for a single dimension task. Further in vivo validation still needs to be investigated. Thank you for your attention.
Thank you. And we'll now move on to the next presentation, which will be given by Pauline Hall-Barrientos from the NHS Greater Glasgow and Clyde, which will be evaluating the clinical suitability of 4D-Flow MRI in pediatric cardiac imaging, insights and experiences.
Thank you. So this image here is our pediatric hospital we have in Glasgow. And recently we have had the upgrade to the XA system on our Siemens scanner. So we thought it'd be a really nice chance to implement the 4D-Flow sequence and compare this to our standard 2D-Flow we have that we use routinely. We did a study over the last 9 months. We studied 33 patients from the ages of 12 to 18 years with varying pathologies. We are a national centre, so we are imaging patients from all over Scotland. Because of this, we were imaging patients with and without contrast. So when they came into the department, we did their normal routine cardiac scan, so all their 2D-Flow, and at the end, if they were quite capable to lie still for another 10 to 15 minutes, we implemented the 4D-Flow acquisition. For the study, we assessed the total time. So this is for the 2D-Flow, included the planning and acquisition. We looked at the image quality, flow conservation, and to see how well the measurements agreed between 2D and 4D. All our images were analysed on the Circle software, and for one of the highlights of the results that we have was just looking at the time acquisition. We're always very pushed for time within our clinical studies. We can see that we are saving time overall, but on average only 6 minutes. Doesn't seem that significant, but when we start looking at particular patients, we saw the 4D-Flow had a wonderful benefit. For one of the examples, we had a patient with HLS with TCPC, and the total scan time with planning acquisition for that particular patient was 41 minutes. And you speak to any radiographer and technician, planning takes such a lot of time to make sure we get these accurate measurements. However, when we compare this to the 4D-Flow, the total acquisition was 70 minutes, quite a long time, but we needed it for a suitable coverage. Looking at the flow conservation, which is very important, we found that there was a 2% error in 4D compared to 19% in the 2D flow measurements. Just a couple of final points. In one patient, we found some significant artifact we can see up here in the image. For that particular patient, we didn't see any metalwork within the chest. The only metalwork that they had was dental. I've only seen this artifact once in another patient who had a metal rod. So if you've seen anything similar, I'd love to discuss this with you. Finally, with all the results we've shown to the cardiology and radiology team, we found that we're quite happy with it. Perhaps we can use this 4D flow for a particular set of patients, maybe not all of them. And for the future work as well, we like to say that we like to try 2 vent acquisitions. And we also have a newly purchased flow pump, which would be ideal to test low vents and how anti-aliasing works for the high velocities. Thank you.
Thank you very much. This switch will be easy to the next presenter because that's you. So please go ahead.
Lucky you. So this is for assessment of pulmonary artery pressure gradients in the pulmonary arterial hypertension patients derived from 4D flow. So this is a project, a sub-project from Dr. Church and Dr. Stephanie Lua. And this was conducted in our Imaging Centre of Excellence building, which is also in Glasgow. We know for these patients, the right heart catheterization is the gold standard, but unfortunately it's costly and carries some risk. So Dr. Church presented ideas, could we use 4D flow and could this be an alternative non-invasive measurement for these particular patients? This is a very small study, unfortunately, but we did have 5 CTEPH, 4 CTED and 7 healthy controls. All these patients were scanned on a 3 Tesla Prisma scanner with a 4D flow sequence all set at a VENC of 150 centimeters per second. The data was analysed using the Circle CVI software, and the pulmonary main artery, the right and left, were segmented. We did analyse the typical flow, wall shear stress, kinetic energy, but we felt we wanted a little bit focus on these pressure gradients. The initial planes for the MPA were placed at the start of the vessel, and for the RPA and LPA at the end of the vessel before they were further vessels are there. And we compared these pressure gradients, the drops from the MPA to RPA, and then from MPA to the LPA. So these are key findings that we found here. And the graph here on the y-axis is the pressure difference between the start of the MPA to the end of the RPA. The black dots here are representing on the average volunteer pressure difference, and we can see there's a large drop at the beginning of the cycle there. And moving on to the patients with CTED, which are in the red triangles, their fall pressure difference drop isn't as significant. It drops to an average of -5. And importantly, we can see there's a huge difference between that and the CTEPH patients, where there wasn't much of a pressure difference at all. Again, we just need to highlight that we need to have more data to have a better need for statistical significance here. And this final image here I'd like to show you is just the time progression of these pressure differences along the vessels. So our top image here is of a patient, and the bottom image here is for our healthy volunteer. So this patient at the top has CTEPH, and you can see for the RPA, there's a slight drop compared to our healthy patient. Thank you.
Thanks again. And for our last speaker, we'll welcome back Ralph Felix Trozadel from Universitas Medicine in Berlin.
Thank you very much. So last but not least, I'm happy to present to you the results of our study impact of sequence types and field strengths on 4D flow CMR measurements, a multi-center study at 3T and 7T, which we performed together with Sebastian Schmitter from PTB in Berlin and Professor Armin Nadel at University of Erlangen. Nothing to disclose. So as you all know, 4D flow CMR enables a comprehensive evaluation of blood flow hemodynamics in the aorta. Ultra-high field CMR at 70 inherently provides higher contrast an improved signal-to-noise ratio, and an increased velocity-to-noise ratio compared to lower field strength, which holds especially promise for 4D-flow CMR. However, it comes with several technical challenges. You all know that B0 and B1 plus field inhomogeneities, potential problems with ECG gating and others. These factors could have a notable impact on measurement results, and we need to know this before going into patient studies. So this was the aim of our study, to evaluate the reliability and comparability across two sites with different field strengths, standard configurations, and acquisition sequences. Therefore, we performed a prospective observational multi-site study with 9 healthy traveling volunteers which underwent 4 4D-flow scans in total, 1 3 Tesla scan and 1 7 Tesla scan at site 1 in Berlin, whereas the 7 Tesla scanner was an older one, and 1 scan at the site of Erlangen with the 7 Tesla scan of the newest generation, the Terra 8, with CE approval. All patients received these 4D-flow CMR measurements, and at site 2 we performed 2 measurements, one with respiratory navigation and one without. We looked at forward flow volume and peak velocities across the 4 different planes along the aorta. These are our results. There was moderate agreement for 3T versus 7T forward flow volume, also moderate agreement for the peak velocity between 3T and 7T, moderate agreement for 7T versus 7T for the peak velocity. However, only poor agreement between ultra-high field for the forward flow volume. There was excellent agreement for comparison with and without respiratory navigation. So in conclusion, there was moderate agreement for 4D-flow CMR between 3T and 7T, moderate to non-agreement between the two 7T systems. So there is an influence of confounders on these measurement results, which we need to look more deeply in the future into it. Let's see at the e-poster, and thank you very much for your attention.
Let's thank again all of our speakers for this nice session. With that, we'll conclude and see you back here in half an hour.